Okay, let's unpack this. We are diving deep into a stack of source material you've shared with us. Essentially, it looks like a really comprehensive set of revision notes or maybe a clinical overview focused specifically on acne vulgaris.
That's right. This material lays out pretty much everything, from the definition right through to complications.
hmm
Our mission here is to go through it together, pull out the most important nuggets of knowledge, clarify the key concepts, and really get to grips with this very common condition quickly and efficiently. And we're sticking only to the information you've provided in these notes.
Think of it as taking these detailed notes and turning them into a high-yield conversation, highlighting what's most crucial for understanding acne vulgaris.
Perfect. So diving straight in, the definition. What is acne vulgaris, according to this material?
Well, it defines it as a common skin disorder, but crucially, it's not just any disorder. It specifically affects what are called pilosebaceous units.
Right, the hair follicles and the oil glands attached to them.
Exactly.
So it's tied to these specific structures in the skin rather than being like a rash that can just appear anywhere.
Exactly. And the defining characteristic, visually, is that it's a chronic inflammatory rash. The notes list the telltale signs.
Yeah.
You see the comedones, those are your whiteheads and blackheads, alongside inflammatory bumps like papules and pustules.
And then in more severe cases.
Yeah, it progresses to deeper lesions like nodules and cysts.
Okay. And where does it typically show up?
The source points to the face, neck, chest, and back as the common areas. It also highlights that it's primarily seen in teenagers, and interestingly, mentions right up front that milder forms often don't require any formal medical treatment.
Okay, so it's a specific condition, affects particular skin structures, got a range of appearances from mild to severe, usually in teens, and not always needing intervention. That sets the stage.
Right.
Now the material moves into the causes the etiology. It's clearly not down to just one thing.
Absolutely not. The notes really emphasize it's a combination of multiple interacting factors coming together.
What are those key factors the material lists?
Okay, so we're looking at hormonal changes,
Yeah.
which, thinking about the teenage prevalence makes a lot of sense.
Sure does.
Then there's increased sebum production. That's the skin oil produced by those oil glands we mentioned.
Okay.
Abnormal follicular keratinization is also listed, which is essentially the cells lining the hair follicle not shedding properly, leading to a blockage.
Ah, the clogging mechanism.
Precisely. You also have bacterial colonization, specifically by a bacterium commonly found on the skin called Propionibacterium acnes. Or, well, now often called Cutibacterium acnes, though the notes use the older name.
Okay, P. acnes. Got it.
And finally, inflammation, which is the body's reaction to these other events unfolding in the follicle.
So it's like these 5 elements, hormones, oil, faulty shedding, bacteria, and the body's response all sort of conspiring within that little pilosebaceous unit.
Yeah, and what's crucial here is understanding how they interact. Hormones can increase oil production.
Right.
That excess oil, combined with the abnormal shedding of cells, creates the perfect clogged environment. Bacteria then thrive in that oily, blocked follicle, and their presence and metabolic byproducts then trigger the inflammatory response we see as those red, angry lesions. It's a cascade.
That cascade makes total sense. And who is most susceptible to this cascade starting? The material lists several risk factors. Some seem kind of intuitive.
Yes, hormonal changes, particularly during puberty or the menstrual cycle, are top of the list, naturally. Family history is also noted as a factor. It tends to run in families.
Right. And then there are some that might catch you off guard, like certain medications.
That's a key point from the material. It explicitly lists medications like corticosteroids, androgens, even things like phenytoin, lithium, certain vitamins, as capable of inducing acne.
So it looks like acne vulgaris, but has an external trigger.
Exactly. Cosmetics are also listed as a risk, especially if they're comedogenic, meaning they block pores.
And humidity. That feels a bit counterintuitive for a condition often associated with oil.
High humidity is indeed included, as are high glycemic index foods in the diet. Now, the source does note later that the link for diet is considered inconclusive, but it is listed here as a potential risk factor to consider.
Interesting. Okay, so we have the definition, the interacting causes, and the risk factors that make someone more likely to experience it. This brings us to the pathophysiology, the how it all happens step by step.
Yeah, this section really connects the dots from the causes to the appearance. It states that the combination of increased sebum, abnormal keratinization, bacterial colonization, and inflammation is the engine driving the process.
And that process starts with the comedones, the blackheads and the whiteheads.
Exactly. These factors collectively lead to the formation of comedones, the whiteheads and blackheads, which are the initial non-inflammatory lesions.
So the blockage forms first.
Yes. And then, if those clogged follicles become further irritated, inflamed, or heavily colonized by a bacteria, they progress. That's when you see the development of the inflammatory lesions, the papules, pustules, nodules, and cysts that define more significant acne severity, according to the notes.
So the pathophysiology is essentially the sequence. Perfect storm in the follicle leads to a clog, which then can become inflamed, leading to the range of visible spots.
Right.
Understanding this mechanism is key to understanding why different treatments target different parts of this chain.
Precisely. If a treatment targets sebum or bacterial load or inflammation, it's interrupting one of those steps in this process.
All right, moving on. Sometimes things look like acne but aren't. The material provides a crucial section on differential diagnoses. Getting this right is obviously vital for correct management.
It is absolutely critical. The material lists several conditions that can be mistaken for acne vulgaris, and knowing how to distinguish them is pretty high yield.
What are the main imposters we need to be aware of from this list?
Firstly, acne rosacea. The notes highlight a key difference. Rosacea typically affects middle-aged individuals, contrasting sharply with the teenage peak of acne vulgaris.
Okay, age is a big clue there.
Definitely. Then there's folliculitis and boils, which can present with pustular lesions that might resemble acne spots.
But would likely have a different pattern or trigger, maybe?
Often, yes. Milia are also listed. These are described as small keratin cysts, typically wider than acne whiteheads and frequently found around the eyes, distinguishing them by appearance and location.
Right, those little white bumps.
Puerperal dermatitis, usually around the mouth, is another one.
And we already touched on drug-induced acne. It's listed here again as something to differentiate.
Yes, because although it looks like acne, the underlying cause is external, triggered by specific medications. The material reiterates examples like corticosteroids, phenytoin, and lithium.
Got it.
Finally, pityrosporum folliculitis is noted, which the material states primarily affects the trunk, offering a location clue.
So when faced with someone with bumps, the notes tell us to consider these alternatives and use clues like age, location, and the specific type of lesion to make the correct diagnosis. That's really valuable.
It's all about pattern recognition and context, as laid out in the material.
Let's talk numbers. The epidemiology section paints a picture of just how incredibly common this is, particularly looking at the UK context provided.
The statistics here are quite striking and underscore the scale of the condition. The material states that acne vulgaris affects a staggering 80% of individuals aged 11-30 years in the UK.
80%. That statistic alone is mind-blowing. It tells you this isn't some rare condition, it's something the vast majority of young people will encounter at some point.
And that prevalence translates into significant demand on healthcare. The notes cite 3.5 million primary care visits annually in the UK just for acne.
Wow, that's a substantial burden on the healthcare system.
It really is. The material also gives us some trends. It's more common in males during adolescence, but seems to be more common in females in adulthood.
Interesting split.
Yeah, and it says up to 95% of adolescents are affected. And importantly, 20-35% develop moderate or severe acne.
So while most get it mildly, a significant minority experience the more impactful forms.
Exactly.
Yeah.
And while the focus is often on that 12-24 age range, the notes confirm it can persist into older age groups. And adult-onset acne, which is more common in women, is often associated with hormonal factors like polycystic ovary syndrome, PCOS, or other forms of abnormal androgen production, linking back nicely to the aetiology section.
Those numbers and trends really emphasize the widespread nature and variable impact of acne vulgaris. Let's visualize it now, the clinical presentation. What does this condition actually look like on someone?
The material gives us a detailed breakdown of the lesion types, which helps us understand the spectrum of severity. It distinguishes between primary, non-inflammatory lesions, inflammatory lesions, and secondary lesions.
Okay, what are the primary ones again? The initial ones?
These are the initial clogs, closed comedones, which are whiteheads, and open comedones, blackheads. The notes classify the presence of just these as mild.
Got it. And the inflammatory ones, the spots.
These are the classic pimples people often think of. Papules, small, solid red bumps. Pustules, red bumps with visible pus. Nodules, larger, deeper, often painful red lumps. And cysts, deep pus-filled sacs.
Right.
The presence and extent of these move the severity towards moderate and severe.
And secondary lesions are what's left behind or caused by interaction, right? Like scarring.
Yes, these result from the active acne or attempts to manage it. The notes list scarring, pigmentation changes, either darker or lighter marks, and excoriations, marks from scratching or picking.
Okay.
The material notes these are more common as severity increases.
So the appearance ranges from small, subtle bumps to significant, painful lumps that can leave lasting marks. And where do we see this most often?
The material provides percentages. 99% of cases involve the face.
Almost universal then.
Yeah. 60% involve the back and 15% involve the chest. It's found predominantly on these sebaceous areas where the skin is typically described as greasy.
And how is the severity officially classified based on these lesions? The notes must have a guide.
They do. It outlines a classification based on the extent and type of lesions. Mild is predominantly comedones, with few inflammatory lesions.
Okay.
Moderate involves extensive comedones and widespread inflammatory papules and pustules.
Right.
And severe is defined by extensive inflammatory lesions, including numerous nodules and cysts.
It also mentions some particularly severe, less common forms, doesn't it?
It does. Nodular cystic acne involves widespread, painful cysts. Acne conglobata is a very severe form characterized by interconnecting sinuses and abscesses.
Oh, sounds nasty.
Yeah. And acne fulminans is a rare, acute, severe form, often associated with systemic symptoms like fever and joint pain. Needs urgent attention.
Okay, so we can clearly picture the range now, from a few minor bumps to these widespread, painful, potentially systemic conditions. Now, what about investigations? Does everyone with acne need tests?
This is a key takeaway from the notes. Typically, the diagnosis of acne vulgaris is made clinically based on the history and examination.
Just by looking and asking questions.
Pretty much. And the vast majority of patients do not require further investigations.
That's important. Investigations are the exception, not the rule. So when would the notes suggest further tests are warranted?
They are reserved for severe treatment refractory acne, meaning it's severe and not responding to standard treatment specifically to look for an underlying cause.
Okay, so if it's really bad or just not getting better, what kind of underlying causes would they be looking for?
The materialists exploring possibilities like polycystic ovary syndrome, PCOS, pituitary adenomas, or maybe anabolic steroid use, linking back to those hormonal influences we discussed earlier.
Right.
The notes specifically mention that in children showing signs of virilization, premature development of male characteristics, serum androgen levels should be measured.
That makes sense. Investigating if hormones are driving it in unusual cases. Any other specific investigation mentioned?
Yes, a skin lesion culture might be considered for patients not responding to treatment, noted as a way to exclude gram-negative folliculitis.
Which can be a complication of treatment itself.
Exactly, particularly with long-term antibiotic use.
So investigations are targeted, and typically only when acne is severe, resistant to treatment, or if there's suspicion of an underlying condition. It's not standard practice.
Right.
That brings us to management. How do the notes suggest treating this condition? Seems like there'd be a lot of options.
There are. The material provides a clear overview of treatment options, ranging from topical applications to oral medications. This list includes topical retinoids, benzoyl peroxide, topical and oral antibiotics, oral contraceptives, spironolactone, and oral isotretinoin.
Quite a toolbox. And there's also non-medical advice, presumably.
Yes. Basic skincare is covered hygiene, avoiding irritants, and the crucial advice not to pick or squeeze lesions, which can worsen inflammation and scarring.
That's always tempting, but bad news.
Totally. The notes also mention that the link between acne and specific things like smoking or dietary restrictions like avoiding high glycemic index foods is considered inconclusive in this context, which is interesting.
Right, so focus on proven treatments first. And there's a structured approach to prescribing a step up.
Absolutely. The notes outline a step-up approach based on severity. Often you start with topical treatments. If that's insufficient, you step up to combinations, then oral agents, and for the most severe cases, isotretinoin.
Can we break down the treatments by severity as the notes do? What's first line for mild?
Sure. For mild acne, the recommended options are topical benzoyl peroxide and topical retinoids.
Right.
It's important to note the contraindication mentioned for topical retinoids during pregnancy or breastfeeding.
Crucial point. And moderate acne, what's the step up?
This typically involves adding oral agents. The note suggests combining topical antibiotics with topical agents like benzoyl peroxide or retinoids.
Okay.
Or using oral antibiotics, specifically mentioning tetracycline or limecycline, which should always be used alongside topicals to reduce resistance.
Good tip. Anything else for moderate?
Yes, for females showing signs of PCOS, a combined oral contraceptive can be considered, again, used with topicals.
And for severe acne, the really tough cases.
The definitive treatment highlighted for severe cases is oral isotretinoin. However, the notes strongly emphasize that this requires specialist prescribing and careful monitoring.
Yeah, I've heard about the strict protocols for that.
Exactly, including regular pregnancy tests for women of childbearing potential due to significant risks. Referral criteria listed include severe cases, any diagnostic uncertainty, significant scarring, or significant psychological distress.
That makes sense. The more potent treatments have more risks and need specialist oversight. The material also mentions managing scarring.
Yes, the primary goal is prevention through early effective treatment of active acne.
Stop it before it starts.
Right. For existing scars, the notes list options like laser treatment, dermabrasion, chemical peels, and microneedling. Significant or persistent scarring is also listed as a reason for referral.
So it really is a multi-pronged approach tailored to the severity and the individual's response. What about the prognosis? What's the usual outlook according to these notes?
The prognosis section notes that acne vulgaris can persist for several years, but generally tends to improve significantly or resolve completely after the end of growth, sort of post-adolescence.
So while it's common in teens and often gets better, it's not guaranteed to clear up for everyone.
Exactly. As we saw with the epidemiology, it can persist into adulthood or even begin later in life, and the course can be quite variable from person to person.
Finally, let's talk about the potential downsides. Beyond the active spots, the complications, what does the material highlight here?
This section is quite impactful, actually. It lists scarring, dyspigmentation, changes in skin color, and low self-esteem as potential complications, noting explicitly that these can result in significant morbidity.
And the psychological impact is really emphasized here, isn't it? More than just feeling a bit down about spots.
It is. The material is very clear that the psychological and social impact can be profound. It lists anxiety, severe depression, and even suicidal ideation as potential consequences. Low self-esteem can lead to social isolation, bullying, and significant stigma. This aspect is often underestimated, but has a truly significant impact on quality of life.
Absolutely. It's crucial to remember it's not just a cosmetic issue. It can severely affect a person's mental health and social engagement.
And the physical scarring itself is often permanent. The notes mention it's usually atrophic, causing indentations, and can result from both deep and even superficial lesions. A statistic cited is that about 1 in 5 individuals experiences socially obvious scarring.
1 in 5 individuals having socially obvious scarring, that statistic, really brings home the long-term physical reality for many.
Yes, and the risk of scarring increases with the severity and duration of the acne. Post-inflammatory hyperpigmentation, those dark marks left after spots heal, is also highlighted.
Especially in some skin types.
Yeah, noting it's particularly common and sometimes persistent in individuals with darker skin types.
Any other complications noted?
The material mentions gram-negative folliculitis as a possible complication of long-term oral antibiotic treatment, sometimes requiring a switch to alternative antibiotics, like trimethoprim.
So even the treatments have potential complications that need to be considered and managed.
Right. What's striking when you pull all this together is how a condition often dismissed as, a teenage rite of passage or purely cosmetic is actually a complex interplay of biological factors with a wide range of presentations, requiring a stepped-up management approach and carrying the significant potential for long-term physical and, importantly, profound psychological scarring. Understanding this condition from these notes isn't just about identifying the spots. It's about recognizing the full potential impact on a person's life.
That really brings it full circle from the microscopic changes in the follicle right up to the macroscopic impact on someone's well-being and mental health. It's far more than skin deep. Thank you for providing the source material for this deep dive.
Our pleasure. And for anyone listening who's preparing for the MSRA or just wants more resources,
check out pastthemsra.com and freemsra.com.